Okay, good morning, viewers. Welcome to another episode of Monitor Your Health. It's a program where we educate the public on contemporary medical conditions. Today, we're going to talk about kidney failure. My name remains Dr. Femi Ogunremi, and I have with me in the studio today Dr. Adebowale Adekoya. Dr. Adebowale Adekoya is a nephrologist, and we know that kidney failure is a major issue that we have in Nigeria at the moment. If you just do a Google search on social media, you will see a lot of people clamoring for funds to have kidney replacements and all sorts. In order for us to be enlightened on this situation, we brought in a specialist. Thank you so much, Dr. Adekoya, for joining us today.
Thank you for inviting me.
You're very much welcome. Please, can you introduce yourself to the audience?
Yeah, my name is Dr. Adebowale Adekoya. I work with Lagos State Government at the Lagos State University Teaching Hospital, where I presently work as a consultant physician nephrologist and acting director of clinical services and training and chairman of the medical advisory committee.
Thank you so much. We know that kidney failure is a major issue, and we would like to know what actually is kidney failure. What do we mean by kidney failure?
So I will be deliberately simple in the use of language, knowing fully well that the audience is mixed. But just to say that the kidneys are vital organs in the body and they perform functions, okay? When they start to fail to perform this function and that starts to manifest with some things, they will say that those kidneys have failed. Because we've got two of them. And when those things start manifesting, it shows that the combined function of these two kidneys have failed. So, in terms of figures and definition, what you then mean is that the individual now has a percentage function of the kidney, which we normally put as glomerular filtration rate has gone probably below 15 mils per minute per 1.732 square meter, or that the person now needs replacement therapy, okay, in form of dialysis or that. But kidney failure itself could be something that's happened acutely or something that is resulting over some period of time.
Right. Thank you so much. So we know what it means now. So the kidney is not functioning at the level of about less than 15. It's at less than 15% in terms of its functionality. Now we see quite a lot of people clamoring on social media, having suffered from kidney failure, requesting for fund for kidney transplants or for the treatments one way or the other. So what's the incidence? When we look at Nigeria as a whole, or even globally, what's the incidence? How many people have this, and why is it becoming so prominent in our society?
Well, it's a complex mix. So if you talk about the figures in Nigeria and figures globally, most of the figures to latch onto in Nigeria will probably be from community studies, where they've used looking at either persistent proteinuria or those figures I mentioned in terms of decreased glomerular filtration or both. And most of the population studies put them together in Nigeria, they put the prevalence as very, very high. That means the burden of the disease to about 16 to 26%, meaning that if you put that side by side with the global prevalence of 9.1 on the average, that leaves Nigeria as a very, very high hotbed for kidney failure. So, but like I said, you have to look at the premise where that's been defined. Those figures are coming from population studies. But the better picture is what you see in the United States, where they use their own national health and nutrition examination survey study on regular basis to come up with figures. Those figures they come up with will be based on the age group and also be based on the stages of kidney disease. That's more accurate, okay? So if you use that, you'll be able to see that in their own side of the world, they've got what we call gerontalization of the kidney disease itself, meaning that it's happening more in old people, okay? Because as you go into the late after 60s, that's when they had the high figures, okay? And as you come up the figures of the stages of kidney disease, when you have like stage 1, that's when you have the high figure. But when you go down in their own environment, they start having very low figures. So, but we don't have that kind of spread like the NHANS has been able to spread out for the epidemiology in the US. But we latch onto these community figures. And what that bring out is that it's a very high burden in Nigeria.
Right. Wow. So now, I mean, comparatively, it's obvious now that we have, more people in our society developing, the disease. And there must be reasons for this. Why?
Yeah, of course. Now we know that we are in the hotbed zone of kidney disease, no doubt. In the past, it used to be why, but there's no so. I mean, we don't have so much of confusion anymore, knowing fully well that by virtue of the fact that we are Black and specifically Nigerians, Southern Nigerians to be specific, we have the genetic predisposition to not just the kidney disease itself, also to hypertension, which is the major cause of kidney disease. So it's obvious that we are in the hotbed zone. But again, another thing that you can put to that is because now we have better awareness, we have better ways of diagnosing this disease condition that will have passed unnoticed in the past. So putting all this together, we can then see the reason why we are now every day waking up to the news of kidney disease and its antecedent complication in our environment.
Right. Thank you so much. We're in an environment where we have a lot of taboos. We have a lot of, mysteries that people develop this thing. And the next thing we hear is, this is because somebody is doing something remotely, somehow, spiritually, causing this problem. Or there are some other, traditional sort of beliefs that leads to, this condition. Can we address that? How does that fit into the mix when we look at, the scientific explanation of the cause?
Yeah, so this is what we have to battle in this part of the world when we talk about kidney disease and its attendant complications. We still deal with people who believe that it's coming from some myths put together. But yes, that's who we are. But with enlightenment like we're doing now and further education, people will get to see that we have scientific basis to explain some of this. And good enough, there are treatment options available. The only sad part of it is that if we don't pick them early and they become, people come late for treatment, then it might not be as good as we expect in terms of outcome. So there are taboos, there are myths, but we just need to continue to educate the populace.
Thank you so much. And now that we talk about taboos, we talk about the myths, we talk about, the fact that, this is a major thing, in our midst. And then you talked about, early and, late presentation. I want to touch on the aspects of, the presentation. We're looking at it in the terms of how they present, because we believe that some situation, which is the major one that we'll find on social media, people say, oh, the kidneys are not functioning. Then they need kidney transplants, and then they're clamoring for fund. How does that relate to the presentation? The very early presentation, late presentation, and the type of, possibly the type of the kidney failures.
Yeah, we have peculiarity for kidney disease and manifestation, especially on chronic basis. You definitely might see people who never knew they have kidney disease. So most of the people who come on social media and the rest are probably those who have actually reached the late stages of kidney disease, probably now needing renal replacement therapy. And unfortunately, that actually form a tip of the iceberg. Okay, that's a very tiny proportion of those who have this kidney disease. For example, in the United States, about 2017, the ENHANCE study was able to conclude that about 37 million people will be definitely perhaps living with the kidney disease that we talk about. Just about 1 million then receiving therapy. Okay, that shows you the tip of the iceberg. Those that will come, unfortunately in Nigeria, those that will come as crash landers. They come when those signs and symptoms of, kidney diseases in terms of uremia are there. And even when they start begging for funds on social media, they actually have little time left, okay, depending on the type of the primary cause of their kidney disease. So the earlier you can pick this condition, the better. But because it doesn't really show you much in terms of signs and symptoms in the earlier part, you then need screening. Okay, and that's a whole lot of debate on its own, because we have different guidelines. Americans in their latest American College of Physicians guidelines saying you don't treat people without symptoms. But thank God that recommendation has been questioned by the ASN in their latest release to say no, we have to continue to screen either you have signs or symptoms or not, because the disease we are talking about doesn't really show anybody any signs until late stages. So in Nigeria, we have to now say, how do we go about it? Maybe we'll come to that later.
Okay, all right, thank you. So how do people actually present? I know screening, we might still even have to talk about this screening, because personally, I think I'm interested in this. So how do people present with kidney failure? What signs would people see before they start saying, okay, yeah, this is tending towards it?
So physiologically, the interesting thing about the kidney is that when it starts to fail, you have about 1 million left from the kidney. And when they start to fail, they have this innate ability to continue to compensate. Okay, they then amplify hyperfunction. That looks good, but in the late stages, those I can do it type of thing they've put on themselves then start to tell us deterioration in terms of function and structural damage. You don't get to see all that until you get to, like I said, late stages, at which point the percentage function, when you start to see increased creatinine, increased urea, it means that the function has actually halved. Okay, that means it was doing 100%, it's doing like 50% now. That's when you start seeing those creatinine creeping up, maybe by 100%. It doesn't really matter whether it's in the normal range. For example, if it gives you a 0.6 milligrams per DL, you're not doing a 1.2, it shows that it's already halved. Okay, but the peculiarity in our environment is that people don't even get to see come to the hospital at those figures I'm mentioning, except you will pick them for screening purposes or during screening purposes. They come when they are, like I said, having the outright signs and symptoms of uremia. Okay, so when we come to the screening part, we'll say more.
Okay, thank you so much. So what sort of investigations, for the audience, they want to know, I'm coming in, there are this issue at the moment. What would they expect in terms of, the investigations when they turned up in the hospital?
Okay, so again, bringing it back home, those that will come to the hospital in Nigeria are majorly crash landers. Those, for example, where I work as a tertiary institution, those that will come are those who have been seen in the peripheral, secondary, and primary healthcare level, diagnosed as kidney disease, then they come. Sometimes some of them have been investigated with simple things. Maybe they've done EU creatinine and they found some derangement, or probably they've done some imaging and then they've seen some structural damages. But broadly, what you need to do is to do some urine workup, blood workup, and imaging. Okay, for urine workup, you probably need simple things like urinalysis. Okay, that means you want to 2017 enhance study able to about workup and imaging. Okay, hello. For urine workup, you probably need simple things like urinalysis. Okay, that means you want to enhance study.
Okay, carry on. Sorry, it's an overload. Okay.
Okay, can I go now? Right. So
yes, please. Thank you.
Do a urine workup. That means urinalysis. You're looking at protein in the urine, blood in the urine, things that shouldn't actually spill into the urine in certain quantity. Then get there, you can pick them up. Then we also do what is called urine microscopy. Again, looking at the microscope for things that shouldn't only be seen or in the quantity at which you are seeing them. And we do blood workup to look at the investigation I've mentioned. Okay, so if you look at the blood, you'll see that the percentage of the red cells have gone down, which is a major feature, anemia is called. Then you want to start suspecting that, okay, we have a problem on our hands here. You look at the blood, you're looking at the markers of kidney damage, though not too great, a storyteller, the creatinine itself. But if it keeps going up, then you know that there's a problem here. Haven't corrected for things like race and body actors in terms of weight and race and sex. But there are things like imaging that people are just doing ordinarily, and they then probably done it for some reasons. Then they see evidence of kidney damage, evidence of kidney congenital anomalies or something. Then those are things that can be done. So speaking in broad terms, you can check the urine, you can check the blood, and you can do some imaging to be able to come up with possible causes. But on the last case screening, okay, you don't get to then do all of this together, okay? There are acceptable guidelines that you can latch onto and say, if you want to do large case screening, you can actually look for persistent proteinuria or just spot protein in urine, or you do some markers, like I said, for the blood. And then when you have all the means, you can also still do imaging here and there, depending on what primary cause you're looking for. But these are what the Americans are quarreled with in terms of doing that on asymptomatic people. But if you ask me, I think what the ASN is holding on to should be the right way to go, knowing fully well that most people that will have this disease will not even have any signs in the first place or symptoms.
Thank you so much for that, for making it so simple for us to understand this. Now, I know there are peculiarities in what we do locally here in developing countries. And obviously, we then look at the resources available as well. You mentioned about, simple urinalysis, checking for protein, blood, and all the other parameters in the urine that will give us, a clue of where we're going. So how do we look at, okay, maybe we should just go to screening. Maybe I'll come back to that question. Let's talk about, the treatment options. And then we can then come back, we can then talk about the screening. And then my question will be relevant at that stage. So we've diagnosed them, they've done the investigations. We now know that this person is in kidney failure, maybe chronic kidney failure. What would them be expecting in terms of, treatment to get them out of this loop?
So when they come with the signs and symptoms, and then the ultimate thing is to have a renal replacement therapy.
Can you hear me?
Yeah, I can hear you. Can you hear me? So when they come with signs and symptoms, the ultimate thing will be to have a renal replacement therapy for them. And that means dialysis in terms of hemodialysis, peritoneal dialysis, or kidney transplantation. But we must note that it depends on at what stage of kidney disease they've come. Okay, those that are requiring renal replacement therapy having it are said to have end-stage renal disease. Just to be careful that sounds like an administrative language, especially in the setting of the US Medicare. But it just means that this person now needs renal replacement therapy. But you must also know that while you are thinking of that, there are some things they have in terms of presentation that you must address. Otherwise, they might not even be alive to get those renal replacement therapy. So the treatment can happen based on how the patient has presented to you. If you're talking about somebody who have been diagnosed of end stage, that means this is gone below 15 minutes per minute, the signs of uremia are already there, there are indications for dialysis, then you dialyze. Okay, but the gold standard for treatment is kidney transplantation, which I think we'll be talking about very soon.
All right, thank you. So, since you mentioned kidney transplantation, what does that mean actually? Let's go into that.
So I said that is one of the treatment options, okay? But it's not just one of the treatment options, it's the best treatment option in terms of cost.
Okay.
And I can break it down. For example, kidney transplant, what it means is that I've told you the combined function of the two kidneys have failed, then you're getting a compatible kidney from somebody else, either living or deceased donor, and you giving it to this person whose kidney function has deteriorated and failed. Okay, so if you do that, what you have been able to do is to improve the person's quality of life, is able to go back to his or her normal daily activity. That's different from hemodialysis, where you have to put the person on the machine that will perform some of the function and also give some drugs to replace some of the function of the patient. And you have to do that regularly to be able to achieve some level of quality of life. But no matter how effective that procedure is, okay, what the hemodialysis machine will do will just be about 15% of what a combined normal two kidneys will do. So, and that will not come at low cost. And because that is not a one-off for a chronic kidney failure, it shows that you're going to be spending a lot. And I can put that in perspective in terms of figure. For example, if you need 30,000 to do that per session, that means you're talking about 120,000 in a week, 480,000 in a month. So you know what that comes to in a year. So you're talking about millions in a year. And how long do you continue that in a country where we know that a large percentage of people who start hemodialysis will not be able to afford continuing it after about 12 weeks in some part of the country? Although Lagos, the figure is a little bit better than that. But for transplant, I mean, the worst case scenario, you're doing a transplant, you're paying 8.5 million. So I'm not saying it's a one-off payment because you're still going to be buying your drugs, but it then comes to more financial sense when you put the piecemeal payment for hemodialysis coupled with the poor quality of life tied to the machine 3 times in a week, 4, 5, 6 hours in a day. I mean, it's not just the right way to go. And that's why we think kidney transplant, taking the kidney that's functioning from somebody, that might sound like, what are you trying to do? But the truth is that we both have we all have 2 kidneys, and we don't need more than one of these to achieve the ultimate function that the kidney should perform. Okay, and when you say we're taking kidney from somebody, it doesn't mean that you just take it from maybe TikTok and Harry. So it means that the person who is giving this kidney has been screened by the nephrologist and has been found suitable to donate a kidney to someone. Okay, and we've published before that Nigerians are actually willing to donate kidney, and that's good enough. And that's why the program in Nigeria for now is predominantly or almost wholly living donor related type of option, living donor type of, transplantation rather. So it means that we should be able to get the message out across to people who are living with kidney disease, that when it comes to the point of at which they need renal replacement therapy, the best option is to have a kidney transplant. The services are available in Nigeria. It is a cheaper option at the end of the day. But if you have to now wait and then make use of other option, less effective option like dialysis, yes, you can get that done. That's available in Nigeria. But unfortunately, the knowledge about dialysis tends to be more in the environment in Nigeria than transplant itself. And that's unfortunate in the sense that dialysis itself exposes the patient not just to financial stress, but also cardiovascular complication, and then make them somehow really not the best candidate for transplant, especially when they stay on that program for too long.
All right. Thank you so much for this detailed, discussion around the treatments options available. Now, I'm quite. I want us to talk about, okay, kidney transplantation. You said is available locally. People, opt for dialysis. I don't know. When you look in the social media or a lot of information that is pushed out in Nigeria, what we're seeing is people want to go to India to have this transplantation, done, or this transplants done, and things like that. So why is that? Is there something that we're not pitching out? If you say that you know, we have the capability, and we have, you know, all the expertise available in the country. Why are people rushing out? Why do we have this, you know, medical tourism going on, which, in my own opinion, shouldn't be the case? What can you say
Yeah,
about this?
yeah, thank you. It's not only for kidney disease that people leave the country to get care outside of the country, even for things like earache, headache. People want to travel. Unfortunately, you can't really stop people from traveling if they've got the means. What we can do is to make sure that we continue to let people know that these services are available. But the good news is that majority don't know that these services are available. But we might still have some who don't. We are able to do most things now locally. We know we still have challenges here, and especially in terms of tissue typing, which you're getting on top of. But majority of the things that you need to get a proper kidney transplanted can now be done locally. Not just that it can be done locally, it's cheaper, and our outcome figures are not bad. Okay, even as far back as 2013 publication in reports in the kidney supplement by Nigeria, and it shows that our figures is not, it's not worse in terms of outcome than counterpart blacks in America. Okay, and for good reason and for scientific reason, it might be worse than the Caucasians, but that's still the picture. Even in the US, if transplant is done in black, the outcome will be worse than if it's done in white. So that should not really discourage us. So what we should be looking at is to be able to let the populace know that we can do this in Nigeria, let them know that it's cheaper to do it in Nigeria, and it's not unsafe or less safe than doing it outside of Nigeria. Again, you say people go to India, but the truth now is that because of the pandemic, those who would love to go to India can actually go, and they've been able to access healthcare in Nigeria. I'm sure you see some viral videos about people talking about, oh, I came to LASUT, I didn't know they do open heart surgery, I was able to do it cheaper and successful. So that's the picture, and that's part of the gains of the pandemic. People will now have to look around the environment and see what is available. And kidney transplant is one of the things they will find that is available.
Thank you so much. We're getting to the end of the program, but I think there are still some important things that we need to talk about. Before we go in there, there's a question here I want us to address. Somebody is asking from the public, when a kidney is when a kidney is defective, can the second kidney take over automatically? That's the question. The person is also asked for the cause of kidney failure. I will suggest you go back into the presentation. We talk about the cause, but we answered this the first question. When a kidney is defective, can the second kidney take over, automatically? It's a public question.
So we have a pair. We have two kidneys, and we don't talk about the function of one. What keeps the body going is actually a combined function of the two. Okay, but just to answer the question in another way, is to say that what I've said earlier, that the kidney by inherent function is able to function when a part of it is failing by hypertrophying, by hyperfunctioning. But I've said that I can do it type of posture that the nephron shows up as having a great effect later in terms of deterioration in function and structural damage. So the answer is, we don't talk about function of one as a whole, we talk about function of the two. And when it's actually derangement in terms of markers going on in the blood, what we are seeing is the function of the two. Scientifically, you can assess function of one by doing some isotopic study, but I'm sure that's not what the person is trying to find out. So the function of the two is what we talk about collectively.
Thank you so much for answering that. So now we've talked about, obviously the causes, how they present. We talked about the treatment modality that is available, and we know that in Nigeria we have, of kidney transplants. Okay, can you hear me?
Yes, loud and clear.
Yeah, thank you. So now, when you talked about the kidney transplants or transplantation, now I know for sure that a lot of people, the medical tourism that we have is usually because people have concerns about either the expertise, either the, the equipment that is needed. And the bottom line is everybody wants to be alive even after they've had. They want the best in terms of quality and even the functionality after the surgery. Are we saying here that obviously with the services that we have available in the country, this is something that we can stick our chest out and say, yes, if you come to have your kidney transplant done in Nigeria, maybe in LASUs or centers where this is being done, you have almost the same result at par when you go to India or you do it in Nigeria. Is that what we're saying?
Yes, that's what we're saying in essence. But also to say more, that the published figure, even as far back as 2013, yes, I can hear you. Even as far back as 2013, published figure in the international supplement, it was saying that we have the same, patient and graft outcome with blacks in other parts of the world, okay? And at that time, we had done 143 in the 5 centers assessed by that author, okay? And the figures were actually promising. But I can say categorically now that between that publication, that time, and now, a lot has actually been done. The figures have improved, even in terms of patient outcome, graft outcome, and we've done quite a lot now. Still, again, to say that majority of what we've done is being done in private setting, but the good news is that it's all being done in Nigeria anyway, and the public setting too are also still actively involved in kidney transplantation. So it is safe. The outcome is same, if not better than some countries, okay? And overall, if you look at, I prefer that you look at the figures and put them side by side with figures coming from African American, figures, okay? Because where you get to see problem is when you put them side by side with Caucasian figures, and that's not scientific enough, because we know that from evidence available, you will do worse in terms of outcome when you're black. So we have no doubt about the safety. We have evidence to show that the outcome is at par with international standard when done in Nigeria. That has been published.
Thank you so much for this. Now, what we want to, having given us all this overview and giving us, the details around, kidney failure in Nigeria, what would be, from your own experience, what would be your advice for the government and for individual while we round up this discussion?
So, well, I think some participants are waiting in the waiting room on the Zoom. If you let them in,
I've accepted all, I think.
Sorry. So don't mind me, I'm turning myself to the host. It's all right, but what I'm trying to say now is that for individuals, I think people should know that because the kidney failure itself have causes in most cases, hypertension, diabetes, chronic glomerulonephritis, some not systemic causes, infection. We need to screen. So give yourself a gift by generally screening yourself. I'm not saying that it's not the function of the government or NGOs to screen, but nobody's going to love you more than you love yourself. So if there are no large-scale screening going on around your area, which should be unfortunate, you can actually just screen and say, okay, let me give myself if you have been told you have diabetes, then you need to now be checking the function of your kidney, knowing that diabetes can cause chronic kidney damage. If you have been told you have hypertension, then you need to be checking the function of your kidney regularly, knowing that hypertension can cause kidney damage. If you have a family history of somebody who has had kidney disease, or had dialysis or transplant, you need to even check more than others, okay? If it says it's fine, keep checking again. And again, there are some hereditary causes of chronic kidney disease. That means it runs in family. But the most prominent of that is what is called autosomal dominant polycystic kidney disease, which in the time past we thought we were not finding in blacks. But if you read the new textbook, we know that it's not just in blacks now, it is not rare at all. So if you have a family member who has had it or has had any form of kidney disease, you must screen. And those screenings are simple things like I mentioned, urine, blood, and imaging. But we also want to encourage large-scale screening. That's where the government issue comes in, or the non-governmental organization, or I mean, people that can go into communities and then do simple things like urine check, blood check, imaging, just to pick up these people in the early stages. Because I've said if you pick them early, there are modalities available to halt progression and reduce the number of people coming to the hospital as crash landers, requiring dialysis, requiring kidney transplant.
Thank you so much. So while we just round up today, I want to thank you so much for your time. I know that it's not easy to get you to come and present for us. So we really appreciate your time. We appreciate your passion to actually to help. And I think to the viewers, I hope we have learned a lot in this presentation. To have more of this, please subscribe to our channel and also follow us on Facebook, Monitor Healthcare Limited. And if you go on YouTube, you can go on Monitor Your Health. Just search for Monitor Your Health on Facebook. You will see us, and then you can get more of this presentation. If you have further questions that we have not answered today, unfortunately, we can't go for more than this because of the time. If you have further questions, please just drop your question at the bottom of this presentation, and we'll pick them one after the other. We answer them, and if you need to contact us, you can also contact us through the Facebook channel as well. Thank you today.